Okay. After this, let's go into the case quiz. Chat box is ready. I would like to see the
Yes,
answer.
sir. Chat box is ready.
Okay. So the question is here, case one. Case one. You see the case. Of course, in this it's pure spectra based, and don't mind if you don't see the background image. There is a lesion here, and we are running the. This is the spectroscopy. What you are seeing. First of all, I want to know whether it's normal, abnormal. Chat box is open, guys. You can type normal, abnormal, spectroscopy. Abnormal, very good. So the question here is the choline to NAA ratio and choline to creatinine ratio I have given. The choline to creatinine ratio is 2.15. Now pick one of the following option. Is it a high grade tumor or intermediate grade tumor, low grade tumor, or not a tumor? Choline to creatinine ratio. Yeah. So normally, very good. Very good. Most of the people have said it as high grade. Minor correction. This is an intermediate grade tumor. Intermediate grade tumor. Definitely, you identified it right. It is intermediate grade tumor is the answer. Okay. This is another spectroscopy of a tumor which is crossing the corpus callosum. And I've taken a large multivoxel and I've given the center area for you to almost at the level of corpus callosum. And you go through the case properly. Let us see. So, of course, conventional imaging is very much favorable. See this. Pick one of the following. Choline to creatinine ratio is 5.1 and NAA to choline ratio is very much decreased. That means NAA is fallen down drastically and choline has risen. So, high grade GBM, definitely. Necrosis is there. And of course, how many of you really attempted to look at the lipid lactate again? When you come to the diagnosis of GBM, in this case, there is hardly any necrosis. So when there is hardly any necrosis, why did you really tell necrosis means hardly any lipid lactate? There is hardly any lipid lactate here. So why did you come to conclusion of GBM? Just keep it as high grade tumor, most probably anaplastic. The word anaplastic is gone now. Anyways, you can call it as WHO grade 4 tumor. Definitely not GBM, because if you don't demonstrate microvasculature or if you don't demonstrate necrosis, you cannot call it as GBM based on our imaging, unless until you have some mutation imaging. So, okay, this is high, so definitely it's a high grade tumor. Okay, this is the normal voxel. This is an abnormal voxel. What is this is a this is what is the my question is what is this lesion per se? First, what is this lesion? Anybody? Where is it located? What is the location of the lesion? Location of the lesion. Where is this lesion located? Okay, this is a hypothalamic lesion. Hypothalamic lesion. The lesion here again is showing. The lesion here is showing choline to creatinine ratio is 1.6. I'm asking you, high grade tumor, intermediate, low grade tumor, not a tumor. If I say it's non-enhancing lesion, yes, it is a low grade tumor. Very good. This is a case of low grade astrocytoma. Choline to creatinine is less than 2.1. The question here is it what is this tumor? 3 questions. What is this tumor? What is the metabolic map showing? What is the, is it high grade or low grade? 3 questions here. 3 questions here. Name the tumor. What is this tumor? Spotter. What is the tumor? Very good. High grade medulloblastoma. High grade medulloblastoma. What is metabolic map showing? What is the metabolic map showing? Metabolic map is not showing necrosis. It is showing choline. It is showing choline. There's a choline metabolic map. You have to look the cellularity, the choline metabolic map. So this is a high grade tumor. Very high choline creatinine ratio, medulloblastoma. And also this you have to understand This is exactly not ventricular type of medulloblastoma. This is a sonic hedgehog variant of SHH variant of medulloblastoma. Medulloblastoma, there are three. Wingless medulloblastoma, which is exactly very near the CP angle, and we have this parenchymal medulloblastoma, which is called sonic hedgehog variant, and you have this intraventricular lesion. So this is a case of sonic hedgehog variant of medulloblastoma, pathologically called as desmoplastic medulloblastoma. So again, this is very important. Myoinositol to creatinine ratio can help you diagnose high grade, low grade tumors. This you can go, but I don't follow it anymore. So this is one slide which any enthusiast who's interested, you can go through this. Along everything comes with pinch of salt. This again, this falls in the range of inflammatory and also infective lesions. So you should be smart enough to differentiate infective and lesions by conventional imaging before you have to come to a conclusion of astrocytoma. Then only you have to look at the spectro. You cannot just put the spectro and say, sir, it can be infective, it can be inflammatory, it can be low-grade astrocytoma based on spectro. Based on the light of conventional imaging, if you can diagnose this will be really useful. So anaplastic astrocytoma are a grade 2, grade 3, 4 neoplasms. You will get this range. That is why I wantedly kept a 2.1 as an intermediate grade, and the GBM, which is very high grade, goes beyond the choline creatinine is very high. So that is the prognosis. Okay, see this tumor. So this is diffusion tensor imaging. So you got you would have got the diagnosis. Now, diagnosis is not the question here. The question is, what can cause bad spectral quality? In this case, we got a very bad spectrum. I didn't like it, It's like there is no ECG, no more peaks, just there is high creatinine. What can cause bad spectral quality? Very large tumor, necrosis, high cellularity, hemorrhagic areas. Very good, excellent, beautiful, wonderful. So most of the kids are really doing extremely well. So this is a hemorrhagic areas are the answer. It is not the large tumor, it is not the necrosis, it is not the high cellularity. So see this diffusion tensor imaging, it is disruption of the fibers. It is not displacing, it is eating away with the fibers, and there is definite fall of the choline to creatinine ratio. So this is a classical hemorrhagic GBM giving a bad spectral quality. Common pitfalls of MR spectroscopy are inadequate technique, voxel placement, hemorrhage within the lesion, all the above. Yeah, so inadequate technique is a pitfall, voxel placement, hemorrhage within the lesion, all the above is the answer. Okay. See this case carefully once again, go through it. I'll have the question following is. In the lecture, somewhere I have leaked the answer. There is a lesion in the frontal lobe and there is edema. Left frontal lobe lesion with choline to creatinine ratio 2.1 and Na to choline ratio 0. Consider the best possibility. See now what I said, 1.5 to 2.2 is an enigmatic area. You can get infective lesions, inflammatory lesions, congenital lesion, neoplastic lesion. The answer is not based on MR spectroscopy. The answer is based on the conventional imaging. Now tell me, what is this lesion? Now comes the game of conventional imaging, where you need to be very strong in the conventional imaging to diagnose this condition. So yeah, I've never been given the contrast. So this is where we fall. Let us see. Let us approach this lesion. The lesion is in the cortical based lesion. I have not given the contrast. And if I given the age of the patient is old age, and the edema is slightly disproportionate. Edema is slightly disproportionate. And if you carefully observe, there is another lesion here in the cerebellum. So this is not a single lesion. What I have seen is abscesses, and definitely it's not an inflammatory lesion. Inflammatory tumefactive demyelination is out of question because it's a very well-defined lesion and a large lesion. So we are left with an infective lesion versus a lesion which is a neoplastic. So we have multiple lesions. Out of my experience, what I have seen is when there is a disproportionate edema, both can be possible. we can take the help of diffusion in these cases where abscess will show diffusion restriction, but metastasis mostly will show inhomogeneity in diffusion restriction. Multiplicity in old age, definitely I'll go in favor of neoplastic lesion or a metastatic lesion. And this case turned out to be a case of neoplastic lesion or a metastatic lesion. So this is a metastasis. Okay, somebody was really enthusiastic in knowing what is this extra-axial lesion and what peak you would like to get in this extra-axial lesion. So cellular lesion, choline is really elevated, and you're getting some random. So it's a broad base towards tentorium. Somebody said schwannoma. No, broad base tentorium. It's a meningioma. It's not in the CP angle. I think I should have given more sections. So what is the peak here you're getting? This is the peak what you're getting. This is an intermediate peak, and we are able to see 135 to 145. We're getting a alanine peak. What is the bird I have given? What bird I have given an alanine peak? Anybody? Black, I agree. Mother-in-law phenomena. Bomb. Yeah, perfect. So yeah, angry bomb. Very good, excellent. So this is a case of bomb, alanine peak. So alanine peak, extra-axial tumor, meningioma. Okay. Again, when there is a very small lesion, spectroscopy fails and it is not really very diagnostic quality images you won't get. So now here we have failed in this spectroscopy. But what is the diagnosis? NCC. Beautiful scolex is seen, and a contrast enhancing scolex is seen. And if you see, this spectroscopy we shouldn't have done, in fact, for such a small lesion. Don't be a cowboy radiologist where you can jump and say, I'll diagnose everything. That is what somebody is already asking. Can we differentiate MRS based on tuberculosis? It is said on textbooks that lactate is a predominant component in the neurocysticercosis. But see this case, it is a failure where you are seeing lipid lactate, and I have performed 135 to 145. Ideally, if this was a lactate peak, I should have seen a doublet here, which is not very classical here. Where doublet is not really seen very well. So basically, the question here was not based on spectroscopy whether it's an infective lesion, inflammatory lesion, or congenital lesion. The answer is peripheral enhanced colic and significant elevation of lactate peak. But again, here there will be confusion whether it's a lipid or a lactate. So the answer says people are reading a lot and say some multiple peaks can be seen in NCC and all. So I am talking as a practical person who have regularly followed MR spectroscopy and all. NCC versus tuberculosis spectroscopy, really it won't give you any great advantage. In fact, the conventional imaging will do. Conventional imaging seeing a T1 hyperintensity with a central T2 satiating. I believe these two signs are very, very specific for conglomeration. T1 hyperintense ring, T2 central hypointensity. T2 central hypointensity is often very neglected thing in tuberculomas. You do not get T2 hypointense ring in NCC, hypointense signal in the NCC. You get in the tuberculomas. And again, one more interesting practical thing which I have seen is scolexes get suppressed in flare. Normally, none of the tuberculomas get suppressed on flare, I have seen. But when there is a lesion of CSF signal intensity suppressing on the flare, then most probably you are dealing with an NCC. Even with so many differentiating points, sometimes you end up stuck between NCC and tuberculoma. In case of too much of ambiguity, call those things as tuberculomas, because the NCC resolves even without treatment, but tuberculosis worsens and there will be endarteritis and it can be devastating. If you put a diligent effort and a hard work in trying to differentiate NCC versus tuberculosis, still if you have a doubt, call those lesions as tuberculomas so that they go for an ATT. And if the patient is symptomatically better, they get a repeat imaging and the lesion disappears. They believe it is because of ATT. and they'll continue the ATT. That's easier than I have seen people whom we have wrongly diagnosed it as tuberculosis as NCC. They have come up with so much of extensive vasogenema and vasculitis, endarteritis, and we have actually had a really tough time treating such patients. And meningitis component is very, very rare in case of NCCs, but meningitis component is really common in tuberculosis. And one more interesting thing which I would like to emphasize is racemose NCC can have conglomeration similar to the tuberculosis. That one thing again you have to keep it in mind. Okay, so this is again peripherally enhancing lesion with squamous lipid lactate peak and NCC. Okay, this is now this guy is been treated with for some lesion, and this is fungal antifungals they have given. They wanted to know whether the tumor is getting treated or not. So it can also assess the treatment response. The choline to creatinine ratio is 1.4. So this in this case, the choline to creatinine, choline is slightly elevated and Na is there, and creatinine is there. Choline to creatinine is 1.4. What is this lesion? Infective inflammatory congenital neoplastic. Yeah, I've given out the answer by mistake. So this is a case of fungal abscess treatment and brain abscess, and there was a lot of elevated lipid lactate due to necrosis. Okay. Okay, this is the lesion. This is the diffusion. There is a lot of diffusion restriction. This is from recent United Imaging, and you can also see this is our video case. In fact, what peak are you seeing here in this lesion? Is it an infective lesion, inflammatory lesion, congenital lesion, neoplastic lesion? If it is an infective lesion, inflammatory, which is the diagnosis? First of all, yeah, because diffusion restriction is the key here. So there is good amount of diffusion restriction. If you carefully see, there is a frontal sinusitis here. Frontal sinusitis you are seeing here. So it's most probably spread directly here, and there is a diffusion restriction here. There is disproportionate vasogenic edema. I think this patient had some valvular heart disease also. So this is a classical brain abscess. And what is the peak you are seeing here? Succinate, very good. So this is a beautiful succinate peak which we have diagnosed recently. This is from our own gallery. And this I already showed this case once again, lethargy and aromatic urine and swollen thalamine, MSUD. So this is the diffusion restriction classical spotter. When you get this beautiful dentate nuclei, brainstem, midbrain, and thalamic diffusion restriction, you can always think about a maple syrup urine disease, brachium pontis, tegmentum pontis, everything will be restricted. So this is again a most of a congenital lesion or a metabolic lesion. Maple syrup and valine peak you can get due to branched chain amino acids. Okay, this is what is the diagnosis? What peak is shot up? What peak is shot up? Yeah, very good. Most of you have got the diagnosis almost there. So this is a elevated NAA. If you compare with the normogram, the NAA should stop at around 8,000 to 10,000. So it is shot up to 14,000. It's very high. So definite elevation of NAA was there in this case. And if you see, this is actually a not a Canavan per se. This is subcortical U fibers are involved. This is actually a double inversion recovery imaging, where you are seeing this subcortical white matter, abnormal white matter will be highlighted. Normally, good white matter will be suppressed. So abnormal white matter will be seen in double inversion recovery much better than normal sequence. So all this is abnormal white matter. Especially subcortical U fibers are involved. So this is a case of abnormal Pelagius Marzbach disease, and all the people who said Canavan is not, they are not wrong. So this is a case of Pelagius Marzbach disease. And again, that fungal abscess case, this is post-treatment. There was lipid lactate elevation. And so what does the lipid lactate peak say? What does the lipid lactate Peak say, yeah, B, necrosis. So that is the answer. Hence, treatment response also could be evaluated by MR spectroscopy. So this is a case of tumor where they have given radiotherapy and there is they have put a VP shunt and they wanted to know whether there is a tumor surrounding the catheter. VP shunt catheter, did they develop this enhancing area? Is it a granulation tissue or is it a tumor? They wanted to know. So we have run an MR spectroscopy and checked for the voxels. And we have seen choline to creatinine ratio is 1.1. So I want to know whether it's a recurrence or is it a radiation necrosis or is it just an inflammation or is it an infection? Yeah, so radiation, post radiation, what we are dealing with is a radiation necrosis. Perfusion is equally beneficial in recurrence versus radiation necrosis. MRS with perfusion is the best for recurrence versus radiation necrosis. You have to diagnose MRS and perfusion are very good sequences to diagnose both. And there is extremely low 1.1 choline to creatinine. So this is again a wonderful case where this patient has received temozolomide for a case of glioblastoma. And this is the perfusion image. I have not given you the spectroscopy. And this is the lesion which you are seeing here. And the question is, this is the, what peak is elevated here is the question. Intermediate TE, what peak is the maximum elevated? I agree for the choline. Beyond choline, what else is elevated here? Beyond choline. So what is the most problem? Residual lesion with lactate peak, recurrent lesion with lactate peak, post-RT changes with lactate peak, new onset lesion with the lactate peak. In fact, this was actually not post-CT changes. Could have been a right answer. C is the right answer. What you are seeing is a Swiss cheese pattern. What you are seeing is low perfusion, Swiss cheese pattern. Swiss cheese pattern you are seeing in case of radiation necrosis. Radiation necrosis, Swiss cheese pattern. Low perfusion, low perfusion. That is how you diagnose a case of parieto-temporal lobe, lipid MRS, low shows lipid lactate. No, where is the lactate? Here you can see this is inverted lactate. Lactate is the highest peak. If somebody asked about which is the most prominent metabolite, don't jump and see the choline. See what is going beyond the baseline. So lactate is the most prominent metabolite here. So again, this is a wonderful case. There was a high grade glioma or glioma in the frontal lobe. They have given RT, and if you see here, there is definite cystic changes. And then what they have done is the patient developed a lesion in the cerebellum post RT. Now they wanted to know whether this is a tumor recurrence or is it a radiation induced tumor. So what they found out was it was around 1.71. The ratio. Now, what is your diagnosis? Is it recurrence, radiation necrosis, inflammation, infection? The lesion actually in the cerebellum, what we are not really. Actually, radiation necrosis, it's fall beyond 1.5. So this is it's challenging. Post RT changes versus it's not that simple. It should fall beyond 1 point. We have to follow up this with serial scans. So this we have to follow up with serial scans. You can't jump and say this is post-RT changes. But whoever said we are right by saying that this patient subsequently turned out to be post-RT changes. But be careful while dealing with such cases. The cerebellum one can be a recurrent tumor. We have to follow it with conventional imaging. But by imaging, today's imaging, what you said is right. MRS shows elevated Na and lipid lactate. Which brain tumor was it? The answer is this. Yes. So we pick one. Go through once again carefully. Carefully, once again see. This is the lesion. This is the lesion. Is it an infective lesion, inflammatory lesion? Not a brain tumor at all. Once again, I'll go through it. Somebody said it's not a brain tumor. So what it is? What it is then? If not a brain tumor, what it is? Chordoma, fantastic. So this is not a brain tumor. I have by mistake typed it as something elevation and all. No, if you would have understood my lecture, it's a flat line like ECG. Nothing is elevated, nothing is down. So it's an enhancing lesion in the arising from the clivus. So the NAA is definitely not there. That much I can tell you. So this is not a brain tumor, and this is a case of clival chordoma. If the lesion is not arising from the brain, generally you don't see a NAA peak because NAA is a neuronal indicator. Great. Last 2 or 3 cases, we will conclude the lecture. What is this? Tumor. Is it a high grade metabolite signature I have given? Only you have to look at the ratios like this. Choline to creatinine, if you want to see, this is the choline to creatinine ratio. Na to creatinine ratio, you have to look at here. So choline to creatinine ratio is this much. Is it a grade the tumor again? So these are very recent additions. That is what I said. Intermediate grade or high grade tumor is good. So that is what I have done is I have called it as WHO grade 2 tumor, and I have just closed it off. This is special gift to be given by Sanjay for the person who diagnoses this sign correctly and who diagnoses this lesion correctly.
Sure,
the
sir.
choline to creatinine ratio is 1.6 here. And my question is it what type of lesion it is? The lesion is next into the fourth ventricle. And is it an infective lesion, inflammatory lesion, congenital lesion, or neoplastic lesion? Again, go through the image. What is the sign also? If somebody types it. You're lucky, Sanjay. Your money is very. So this is a case of inflammatory lesion, and this is a case of PML, progressive multifocal leukoencephalopathy. This is called lobster's claw sign. Claw sign of lobster claw sign. You get it in a PML. So you get this hyperintensity around the dentate nucleus, middle cerebral peduncle, and everything. So this is a case of lobster claw sign in a case of PML. Okay, I think last before case, based on this 2.2, again, the grading of the tumor, you can directly go, you easily do it. It's a malignant lesion, intermediate grade, choline peak, peripheral ring enhancement. We conclude with the last case. They have not shown much of these cases. What is conventional imaging showing? Anything in specific? What is the sign here? Multiple lesions sitting attached to each other. And if you carefully see, what is the choline to creatinine ratio? 1.34. This is recent United Imaging edition. Choline to creatinine ratio is 1.34. What is the diagnosis? The question is it infective? Is it congenital? Is it inflammation? What is the, if so, what is the diagnosis? Fantastic. What is the diagnosis? Conglomeration, tuberculosis. And again, if anybody seen that there is elevation of lipid lactate also in this case, this is lipid lactate. So there was elevation of lipid lactate also. Okay, so now I want you to list 1 or 2 pediatric imaging. Pediatric imaging is common indication. They do multiple places they place the voxel and they look for this specific peaks. What I say, lactate to creatinine ratio will diagnose this grading of the HIE. So that is one thing. And glutamine also elevates in HIE. Pediatric imaging, it's important, and especially MRS can detect the damage of the brain even when before is visually seen. So when there is a grade 1 HIE, if you are getting normal brain, you run a MR spectroscopy, look for this lactate to creatinine ratio, and you can definitely tell there is some grade of HIE. Instead of calling for follow-up, you can run a spectroscopy sequence and you can tell them. It's one very important indication. Fleeting lesions, one day infarct was done right side, one day it was on left side, and it is just shifting. So 15 months later, again, it went to temporal lobe. So if the patient had lactate elevation, what is the diagnosis? Fleeting diffusion restriction, fleeting strokes. What is the diagnosis? It's a case of melas. Melas, you know, patient had lethargy as a symptom and there was elevated lactate. What is the diagnosis? What is the diagnosis? Diffusion restriction also is there. If you hold something in the diet, this patient will become normal. What is the diagnosis? So this is a case of Leigh's disease, lethargy, elevated lactate, periactal white matter, and everything. So that is our own case of Leigh's disease. So ultimately, there are so many articles saying it is useful, not useful. If you carefully see some articles, most of them are saying MRS is really useful. I've gone through and just given it. And recently, there are so many guidelines. The society of all the societies have met, and they have made some guidelines where definitely it is useful in post treatment. One of the best indication pre and post treatment assessment, glial neoplasm versus low grade neoplasm, HIV, seizures, epilepsy, and so many guidelines. They say you can use for Canavan's disease, you can use for demyelination versus dysmyelination. I'll give a simple scenario. You want to put in the report whether query demyelination, query glioma. Why don't you just run a spectroscopy, look at the choline creatinine ratio, which will be generally very low in a case of demyelination. Very rarely it will be high. So because of cellular turnover, it's just a destruction rather than cellular turnover. You can definitely help narrowing your differentials, putting. So ultimately, I just want to ask you whether MRS is useful or not by this experience of so many cases.